Good. Thanks very much. So, first of all, I'd like to say that we saw this coming, and as a committee, we took an hour or so in our last committee meeting to discuss the fact that this was going to be on the agenda here at the BAUS 2018. And so the views I have are representative of my fellow committee members, Darren Smith, who's in the audience, and all the other members. I also want to thank Oliver Wiseman and John Withington because their input into the output that we've produced from this endourology section has been absolutely vital, improving the worth of these databases and these registries. So, like the others, we're going to go through what we've achieved, what we're doing, and what we're developing and where are we going. So what have we done? Well, I think it's been a remarkable journey for BAUS. I think British urology has a status internationally that we wouldn't have had without the data collection that these registries have provided. It was definitely right, 10, 15, 20 years ago, to start this data collection, and it's given British urology, as I say, this unique position. I think also it's changed the mindset of British urologists and trainees, and we have a view on openness, on data collection, on honesty in our data collection that we wouldn't have had without this nationally collected data. The direction is now uncertain, and the process has been expensive, but I certainly feel it has been worthwhile. So the raw numbers, we've been through this with some of the other registries. I'd like to tell the section of oncology, it was the section of endourology that started the nephrectomy audit. And that, as has been shown earlier, has now got a registry of over 20,000 nephrectomies. We've also got 12,000 PCNLs, and we did collect a data set of just over 4,000 ureteroscopies. The data's, what's been real gains, real pluses in collecting these data? Well, the data set hasn't stood still. We're not entering the same data now that we did in 2010 or 2005, and the data set is evolving. It includes things which HES we know is not very good at measuring. It includes stone complexity, definitely missing from HES. It includes patient complexity. It includes complications. I suspect we are in the only country that has a national figure for transfusion rates for percutaneous surgery and nephrectomy. It provides all of us with easy data for documentation for our appraisals and our annual assessments. And as I say, it's changed the mindset of British urologists into one of transparency and open discussion of complications. It's produced a remarkable amount of data, solid data. The projects have been discussed by the section of endourology as a group. We've worked closely with the clinical effective unit of the Royal College of Surgeons. And as I say, although driven by a group of people who have put thoughts together as what questions we should be extracting, John Withington and Oliver Wiseman together have driven a process to produce a remarkable amount of subgroup analysis. And these are just some of the papers that have been published in various journals, including the Journal of Urology, the Journal of Endourology, the British Journal of Urology International, and also a large number of abstracts that have been presented at various international meetings. And again, just to re-emphasize, this has put British urology into a remarkable position. The data sets have evolved, and over the last 20 years, these data sets have become slightly more cumbersome. Data entry is more onerous than it used to be. I enter all my own data. I tend to do it on a weekend on call, where I come in and I spend 4 or 5 hours entering some data. I used to do it at the end of every case, because I could do it, the input data at the end of every case. You can't now do it at the end of every case in quite the same way, so the data collection is more onerous. It doesn't really capture some true information about patient complexity, but again, this is going to evolve. And follow-up data for all these audits has always proved difficult. It is an increasing data set and increasing demand of our time, and it's particularly demanding of our time for those of us who are high-volume surgeons. But there is a big issue. We're not cancer. we're endourologists, and we're not sexy. We don't get funding and all these other support data sets that we've seen earlier this morning and just now that our cancer colleagues are able to collect. So we don't have a national drive. If we're not doing it ourselves, it's going to be very complicated for us to collect this data nationally. And HES data struggles to pick up and record correctly the procedures that we do. So it's relying on us. The evidence that suggests that the evidence has resulted in less dabblers. Fewer low-volume surgeons are continuing to do percutaneous surgery because those who are doing less than 5 PCNLs a year have seen that they're at the far end of these curves and are thinking about whether they should be continuing doing it. I think it does teach us and it has shown us what good transfusion rates, what good complication rates have been, and it provides the open forum to discuss these results. And clearly, mandating data input has changed everything. At this point, I take a little break. That's my wife. She said, and my wife knows I'm giving quite a few talks about this year, and she said, she looked over my shoulder as I was giving this talk, and she said, what, 2 o'clock in the afternoon, after lunch, you're giving this talk? Everyone's going to be asleep. Give us people a bit of a break. So there's a quick break. The 7 ages of man in urology. We go from the youth through to other concerns, to the concerns of the elderly in a urology clinic. And she said, you've got to do something to wake them up in the middle of your talk. So we haven't continued with everything. The audits have discontinued. We did have an audit on upper tract TCC. That had a small number of fantastically enthusiastic contributors, but the numbers were relatively limited, and we have now discontinued with it. Recruitment was slow, the data outcome was limited, but we did as a section make sure we wrote to those people who had contributed, thanking them for their contributions. We did do briefly a data collection on PUJ obstruction, data collection on a disease for us rather than a procedure is much more challenging. And we do constantly review the data set. We have to, I think, over the years ahead, decide what questions each year we're going to focus on. Now we're going to choose a topic as being suggested by the cancer section to look at how we're going to evolve this data and how we're going to continue to produce useful information from this data set. Oliver Wiseman has just stepped down. Will Finch, who's in the audience, is going to take over as our data lead, and we're going to continue to allow these questions to evolve to make sure we continue to get good information from them. There's no question that the collection of this data has stood BAUS in a fantastic position when it's just presenting ourselves to the GIRF project. It's allowed us to generate some guidelines for stone disease, which hopefully are going to be a standard setter for where we should be with treating the acute ureteric stone. And we're waiting to see the NICE standards, which are also going to inform us and set standards for where we should be aiming to be with stone disease. But where are we going from here? There is a possibility of considering whether we should change the focus from treatment to disease. Again, for us as a section dealing with stone disease, that's going to be very challenging. And to persuade you, BAUS and British Urology, to collect data on a single disease rather than do it procedure-based, I think is going to be very challenging. We want to continue to use the data to work with GIRF and with NICE to promote best practice. We want the databases to increasingly evolve. We're not going to just continue with what we've got, but we need to look at them and ensure that the databases do remain alive and active so that you want to continue to contribute data to these databases. But just to reassure you, they are seen every year, every committee meeting. We discuss the databases in our audit section of our committee, and we try to make these live and real so that they do continue to produce useful data and publishable data. The further questions I then ask to BAUS is exactly as Tim O'Brien asked this morning. We spent the last 10 or 20 years saying open data collection is important. We've made it mandatory. Now we're going to suggest to the BAUS members that actually you don't need that information anymore. We know that for endourology, the data we provide is better than the data collected by HES. I'm slightly concerned that we're honestly going to be able to say in 2015 that we know and we knew what the transfusion rates and the complication rates were for PCNL, but in 2020 or 2025, we may not know that information. And I have particular concerns that as we are producing a tranche of urologists whose experience is increasingly limited because of the evolving training programs, that our junior trainees, our junior consultants will need that information to provide in their appraisals to show that they're meeting certain standards, and it will be very useful for them to be able to provide that information. And I have concerns if we're not able to, BAUS as an organisation is not able to provide them with a system that gives them that information. Benign disease isn't sexy. By producing these audits audit sets and registries, we've let endourology and British endourology hit the headlines, and we need to make sure we keep it there, and these data sets have allowed that to happen. We wait for the discussion. We're, as an endourology section, we're very keen on this being funded through BAUS, because we feel if we lose our national data collection, we're going to struggle then to continue to collect useful data. Thank you very much.
Thank you, Jonathan. Just wondering if Roland's in the room. Not yet. So can I ask...
Should we ask Henry?
Yes, please.
So we'll just change the order slightly. If I could invite Henry Lazarowicz from Broad Green Hospital, Liverpool. So Henry's going to represent the generality of urology. We don't actually have officially a subsection of general urology, but I'm sure Henry represents a very large number of urologists in the UK who either have a purely general urology practice or have a significant core urology practice alongside their subspeciality interest. Thank you, Henry.
Thank you very much. Good afternoon, everyone. My name is Henry Lazarowicz. I'm a consultant urologist based at the Royal Liverpool and Broad Green University Hospitals just up the road. And I've been asked to represent the generality of urology. So, as we know, there are currently 6 national audits which are inextricably linked with consultant outcome publications, which are mandatory. None of these particularly target general urology, and we know that 2/3 of consultant urologists contribute to these audits, but there are a third of us who don't. Unlike the preceding speakers, who all represent well-established sections of urology and whom the majority contribute actively to these audit processes, I am representing the generality of urology, which does give me something of a blank canvas upon which to do this talk. And depending on your perspective, this could be perceived as being a golden opportunity or a poisoned chalice. Who am I? I am a general urologist. I work in a university teaching hospital. Like many general urologists, I have my own specialist interests, which are non-muscle invasive bladder cancer and clinical research. By design, I don't do cystectomies, and therefore I do not contribute to any of the current national audits. So, what are my views on national audit? Well, there has to be something in it for us and our patients in terms of improving clinical practice and our understanding. What it shouldn't become is an exercise in generating data with which we beat ourselves up with and just merely generate comparative league tables. And as alluded to before, I have anxieties about time and resource concerns. Historically, there's a potential for a lot of extra work involved in adding audit data. And as we know historically, a lot of this goes unfunded and unsupported despite the drive from central government. So, what surgical outcome measures should we use? Well, these need to be objective, they need to be easily measurable and be meaningful. One suggestion I have, it'll work close to my heart, is looking at 3-month recurrent rates post-primary TURBT. However, with the current setup of BAUS audit anonymisation, this is likely to be a significant hurdle towards using this as a measure. And any measure, ideally, should be all-encompassing, covering all of general urology. However, we may need to concede that there is no single index or reference procedure by which we could be benchmarked. And of course, the more philosophical question, which has already been addressed today, is whether the focus of BAUS should be redirected towards more clinically directed questions. And by this, the concept of collaborative research as opposed to competitive research and audit, looking at rare conditions, building up registries of conditions which we see infrequently in our practice and don't really have lots of data on the natural history of, or looking at novel and niche treatments. And that's particularly applicable in benign prostatic surgery at the moment, where there's been an explosion in novel techniques, and there's no real global comparator amongst all of them. So, where do we turn to for answers? As has already been alluded, a section of general urology, it doesn't exist, and nor are there any foreseeable plans for its existence in the future, as per the President's recent newsletter. However, this is not necessarily a bad thing, because I'm sure most general urologists here will subscribe to one or the other sections of urology. So, rather than just provide my own opinion on this, what I did was I conducted a snapshot survey within the Northwest region, which evaluated the current levels of BAUS activity and also sought the views of contributors on its effectiveness, and then asked the question how and whether general urology should engage in the process as it currently stands. So, looking at the demographics, sorry, I think I've missed a slide there. Yeah. The Northwest region, comprising of Merseyside and Manchester and up towards the Lake District, there are 126 practicing urologists and 8 locums. This survey was conducted within my own trust and a recent Northwest Regional Audit meeting, and there were 38 responses, which accounts for approximately a third of the workforce, which is not too bad considering it was a snapshot questionnaire, and I'm indebted to my colleagues who took the time to fill it in. Of these, 12 consultants were district hospital consultants and 25 were teaching hospital consultants. If we look at the demographics, the graph on the left demonstrates consultant outcome activity according to unit size, and this covers the whole spectrum of units from the 2-man unit through to the 11 consultant units there. And the boxes in red represent the number of consultants currently engaged in national audit, and the ones in blue who are not. When you drill down into the data, in terms of district hospitals, only a third of consultants participate in any of the national audits there, which compares with nearly 80% of teaching hospital consultants. In terms of the audits which are covered within the survey group, by far the commonest was nephrectomy, followed by PCNL, and then cystectomy, prostatectomy, and then the benign urethroplasty and female continence audits. When the survey asked about how many patients had actually asked the contributors about their data, only 2 out of the 22 consultants had been interrogated about their consultant outcome figures, of which 1 of the 22, it had influenced patient decisions. In terms of manpower resources, they were asked how many cases they enter into the national audit and how long it takes. The mean figure was 1.1 cases per week per consultant, and the mean time was approximately 29 minutes, which equates to about 25 minutes per case being entered. And who's entering this data? Well, the vast majority was being entered by the consultants themselves, and about a quarter of the data was being entered by data managers, with very little contribution from the junior doctors. Before I talk about the benefits and drawbacks, which the surveyors were asked about, I'll just make a reference to the strategic plan, and we saw this slide earlier on. The mantra of the strategic plan 2020 is in inverted commas there. A critical review by BAUS was made in the autumn of 2017, asking the 4 key questions there. And using these key questions, I summarised the responses from the survey in terms of people's views on the benefits and drawbacks of the current audit process. So if we look at the benefits, in terms of telling us about quality, 4 out of the 22 respondents said they used the audit for purposes of appraisal and their own audit. In driving change, there were 6 out of the 22 who said they used it for comparative purposes, looking at transfusion rates, length of stays, complication rates and outcome, One acknowledged that these audits have driven centralisation of complex cases, and a further respondent indicated that they had actually used audit to review their own technique and modify it accordingly. In terms of drawbacks, if we look at effective delivery, there were 3 responses saying that these audits were of questionable benefit, 2 cited them as being time-consuming, and 1 commented on the fact that audits really should be there to improve the care of the largest group of patients, and quoted the fact that PCNL only accounts for 2% of stone patient work. And 1 further comment from a respondent was that although they contributed to audit, it wasn't relevant to 99% of their own practice. As we've alluded to already, there are organisational and reputational risks. The commonest comment was that data is inconsistent, is surgeon reported, it's not mandatory, and therefore prone to an element of gaming and publication bias in terms of a reluctance to perhaps publish inferior results. There's a lack of external validation, was quoted by 3 consultants, a lack of long-term outcome data, which we've talked about over and over again throughout the course of today, and also the need to reflect case complexity. Sorry, this seems to be auto-advancing the slides. When the question was posed, should general urology contribute, if we look at the 2 pie charts here, the one on the left is consultants who currently don't contribute to national audit, and the one on the right is consultants who do. What is clear is that there's an even split, and 50% of respondents felt that we should contribute, but what is apparent is that there's certainly a more decisive move towards saying no amongst those who already contribute to national audit. So, what measures should we use? A number of generic suggestions were made: infection rate, length of stay, patient satisfaction and re-intervention. And a lot of these you can acquire from HES data. 3 diseases and procedure-specific measures came to light as a recurring thread, and they were TURBT, TURP and stone disease. And I've highlighted some of the ones there which I think would make good benchmarks. 3-month recurrence rate. One quote was time to resection for PT1G3 disease, and I think this perhaps is more a reflection in terms of service provision rather than technical ability, and so perhaps looking at recurrence and progression rates within this cohort may be a better benchmark. And also the presence of detrusor muscle. However, I suspect if we use that, then there may be an element of gaming in terms of people taking cold cut biopsies just to get a bit of muscle in the histology report. Perhaps me being a little bit cynical there. In terms of TURP, one suggestion I thought was excellent was looking at re-TURP rates at 5 years. And this, of course, could be applied globally across the whole sphere of outflow surgery and procedures that we use. And other measures were there, some perhaps a little trickier to use, such as estimating blood loss. And of course, with stone disease, one suggestion was a percentage of patients needing second look URS or intervention post-primary treatment, which I thought would be an excellent benchmark. And other suggestions including percentage of patients having CTs in A&E and time to treatment or time with stents. And again, the latter, I think, are more a reflection of service provision and service availability rather than technical ability there. I also mentioned collaborative audit, and I think this is certainly where there's an appetite for looking at rare diseases and conditions. As I say, my area is in bladder cancer, but I'm sure you can all think of areas within your own specialisation in terms of looking at the treatment outcome for diseases which we have very little or scant data, such as micropapillary variant bladder cancers, keratinizing squamous lesions, and metaplastic bladder lesions. And also looking at niche and novel treatments and technologies in terms of their short and long-term outcome. And I think a particularly pertinent topic at the moment will be bladder outflow surgery, as I say, with the explosion of various therapies. And we don't want history to repeat itself from the late 90s, where new techniques came along and then disappeared as we realised they weren't particularly effective. So, what are the potential hurdles? They're the usual suspects: funding, time, clinical motivation and reward, completeness of data sets, and this is where, as we've already said, cross-referencing with other databases is going to be critical, and also the lack of long-term outcome data. As we've heard from our speaker this morning, it's taken 14 years to set up her work, and so bureaucracy and red tape is no doubt going to be a big hurdle. And then I think the big one, of course, is security and data protection. We live in an era where there isn't barely a month or week go by where there isn't some scandal or some data loss or hacking of computers. And I think the public is rightly becoming somewhat more paranoid about what we do with their data. And I think we need to engage the public in this so that they know that this is their data, and if we help them, they need to help us in terms of accruing this data. So, in summary, there are mixed views as to whether general urology should contribute to national audit in its current form. Time and resource concerns mentioned. There have been demonstrable performance benefits from national audit, but the process in its present form, as we concede, is flawed. And if general urology were to contribute, the focus really should be on the TURPs, TURBTs and stone treatment using the outcome measures as we've specified there. And there is an appetite for collaborative audit and data collection for novel therapies and rare diseases. Any questions?
Thank you, Henry. We'll take questions at the end because we still have Roland. Thank you for making it, Roland. So Roland Rees is a consultant urological surgeon at University of Hospital Southampton and is the current chair of the section of andrology.
Thank you. Sorry I'm late. So yeah, just to run through what's going on in the AGUS section. So the main audits we've got or had are urethroplasty, penile implants, and there's been a sort of almost a historical audit now on Peyronie's disease, which not many people were inputting into, and therefore that's been sort of archived. Urethroplasty, that's probably the most successful of our audits, in that it collects mostly operative data, follow-up data on everybody having urethral stricture disease, collecting parameters such as cause of the stricture, etiology, age of the patient, previous operations, how many ureterotomies they've had, etc., the symptoms they presented with, whether they've been doing self-dilatation or not, whether they've had a flexi-cysto or a urethrogram prior to that, where the stricture is, what procedure was performed, what size of catheter, all these sort of intraoperative details. In terms of the follow-up data, when they come back to clinic, typically 3 months post-operative, have there been any intraoperative complications? Have there been any post-operative complications? What are the symptoms following surgery and the catheter removal? Has there been any recurrence? What the post-op flow rate is as compared to the pre-op flow rate? And also the parameters of data quality. So how long did it take for the data to be inputted? And what percentage of HES figures are there being inputted? So over 7 years, and I thank Steve Payne for going through all of this annually and feeding some information to me. He's been diligently sort of going through stuff. 7 years, there have been almost 5,000 urethroplasties performed in 44 different centres, but the vast majority of them are happening in 12 centres. So there's a glut of high volume, medium volume centres, and then a long tail effectively. And again, Steve's forwarded that sort of map, if you like, of urethroplasty, which you can generate according to volume. Having said that, there are noticeably one centre in particular in the Midlands not inputting huge amounts of data, so there's a bit anomalous, but you know, it's as good as we've got. What are the issues with this audit? Well, just like I'm sure you've heard all afternoon, surgeon-reported data. We are putting it in at the time of the surgery or a bit later, sometimes a lot later. It's incomplete, particularly the follow-up data, so we won't have 100% of patients followed up. There is a delay, myself being guilty, so there's a bit of inequity in terms of infrastructure, shall we say, across the country. So some people have got hordes of clinical fellows perhaps helping out, some people are operating on their own, and all these factors can impact on your ability to keep up to date with data inputting, and there's a spread of delays, if you like, on how long it takes and bulk uploading of data in some cases. And arguably the most important outcome measure for urethroplasty is not death or sort of acute things, but actually the long-term outcome. What is the odds of you requiring another intervention in 5 years and 10 years? Those are the important parameters for urethroplasty. Reintervention rate over a long time. And that's not particularly well captured in this database. So we've got a lot of data being collected. Questions, I mean, I wasn't around when the questions were designed, but have you had symptoms for weeks, months, or years? I mean, it's difficult to sort of do anything with that sort of data. And yeah, we've used volume figures as sort of, it's been a good driver. So once a year, baggers meeting, a league table basically of who's inputting their data, how many are you doing, and that I think has probably helped the sort of audit process along. Then there's a question of who owns the data, who can take it and publish on it and that sort of thing. And yeah, to date there haven't been any publications. But having said that, tomorrow there will be some abstracts on this data. Steve Payne's presenting the outcomes, so we look forward to that. Then we've been subject to the consultant outcome publications the last few years on the BAUS website. So 88% of HES urethroplasties are recorded, so that's pretty high, I would guess. But the number of the complications reporting is fairly low, so 1.7% intraoperative, 7.8% post-operative, and 2/3 of the patients having outcome data recorded with a mean length of stay of 1 day. Then you can go on and look at the quality, so that what's actually published on the web. There's the quality of data, as I said, the mean time to data entry. I'll skip over that because the scope of practice, how many you're doing, what region of the urethra are the cases, 53% in the bulbar urethra, 28% in the penile, etc. And then your complication rates, intraoperative, postoperative, and how do the flow rates compare. So that's the stuff that the general public are able to see. What about HES? Well, obviously HES is getting better. I think in the last 5-6 years, maybe the quality of HES data has improved. So we're able to look at the numbers and the activity in different centres. We're able to look at whether it's revision or not. We can look at the length of stay, readmission rates, reintervention rates over time. And that's particularly an attractive aspect, is that you can track patients by their NHS number. So particularly tertiary services like urethroplasties. If I do urethroplasty in Southampton this year and they're admitted to Bournemouth in 2 years' time for a dilatation, then particularly HES can link that up and tell us that actually, although I didn't know about it, HES knows that my urethroplasty has failed within 2 years, and that's potentially quite attractive. As I said, that's just saying the same thing, really. So it can link across the NHS over time. It could be 10 years, it could be 20 years down the line. It's got longitudinal data, and it's pretty consistent, and it's getting better. And it's certainly on a superficial basis, free data. So looking at the HES analysis, the various codes, the last 10 years, in fact, we've seen a 24% increase in urethroplasty numbers and a bit of a drop in the endoscopic treatments, as you would expect. This has been slightly distorted by the open trial, which a lot of us put a lot of patients into, which is a randomized controlled trial comparing these two modalities. But essentially, you can look at the activity levels. This is something I did back in 2011. So slightly historical, looking at, as I say, the slight issue we certainly had, probably decreasingly so, with a lot of low volume centres. You can use HES to look at, for instance, the 30-day readmission rate, and in this graph it was plotted against the volume, and you can almost see a pattern there of the sort of lower volume centres having higher readmission rates. And you can look, this is back in the days of the PCTs, with the forerunner of the CCGs, looking at the incidence, and this is quite interesting data. So you find out where you link the rate of urethroplasty for each PCT in the country, and one is double or triple the other. So you've got some centres down to 0.5 per 100,000, going right up to 4, so 8 times. So certain areas of the country are 8 times more likely to get a urethroplasty than in other parts of the country. So that's really how HES stacks up to the BAUS database, so we could talk about that. Penile implants, that's our sort of second audit. This is a very low volume procedure. It is highly specialised. But these are the issues. There are 2 manufacturers that both collect data by their PIF forms, the patient identification forms. There are consent issues with that, but the 2 companies are not going to collaborate with us or certainly compare or put their data together. There are issues with prostheses in other parts of the body, the PIP scandal, the hips, etc. So personally, I feel that BAUS, or as surgeons, we should know how many implants we're putting in and what the complication rates are, both locally and nationally. But there's no COP for penile implants, and actually there's no regulation at all as to who does them, where they do them, how they do them, etc. And there's some low-volume surgeons again. But the revision surgery can be quite challenging. So the Penile Prosthesis database goes back 8 years, 739 cases, again 32 surgeons and 27 hospitals. And the data input was very slow to start with and has sort of increased in recent years, particularly since 2015. And that graph basically shows the total by consultants. So the median number of implants put in by all these surgeons is about 13, but that is skewed a little by UCLH right at the very end there, high volume centre, doing more than pretty much everybody else put together. This shows the rate of primary implant to revision. So 615 primary implants going in, 124 revisions. Of those, 76 were exchanges, so you need to assume that that's because the mechanical breakdown, exchange it for a new one, but also explantations and revisions, usually for pump problems, reservoir issues, things like that. And the blue bars are in the bottom graph here are revision surgery, and the orange is primary. So what we want to try and do is make sure that revision surgery is being done by the more experienced surgeons. Complications, so we enter the complications at the time of surgery, and my initial impression of this is underreporting, really. One penile implant infection out of 739 cases is probably not. Well, I know it's not because the company reps tell me it's not. So, there's underreporting, and that's one of the issues with surgeon-reported data all around, really. 3-month follow-up, only 12% of patients having follow-up data recorded in this database. But of those 12%, 3/4 of them are using it, so that's encouraging. Going on to HES data for penile implants, again, there's a code for primary and revision. And again, there's been an increase, significant increase, 56% since over the last 10 years in the number of implants. We're now at, as I say, approximately 527 according to HES. Of course, this doesn't record the private hospital data, so may not exactly reflect the database. But essentially, what it tells us is that approximately 50% of the HES cases are being put onto the BAUS database. What do we really need to know about penile implants? Well, we want to know what the reoperation rate is. We want to know what the readmission rate to hospital is. We want to know if the implant got infected or not. And actually, we need to know what the precise complications are. And the problem with HES in this regard is it doesn't really capture that detail, whereas our database does. So in this case, the detail is better on the BAUS database. And of course, it's got a PROM, which HES doesn't have. So I think in summary, HES is pretty good for urethroplasty, particularly long-term reintervention rates or readmission rates. But it's less good for penile implants because there's not enough detail in there. So we may need to continue with some form of separate prosthesis database, whether that's run by BAUS or the companies or another body. So that's my summary. Thank you.
So thank you to all the speakers, and can I get the speakers to come and take a seat here, and Rashmi and I will move to that corner, and then we'll open the floor to discussion. So lots of thought, and I guess I'm just going to share my sort of take home from each of you. And I liked Krishna's thoughts of bespoke extractions to answer specific questions. the thought of patients inputting data is what Nikesh alluded to, and the whole concept of the changing data set and how the endourology section have changed the questions that they are asking themselves. Henry has the whole concept of a lot of us are not entering any data at all to any of these audits, and how do we ensure that the generalist questions are also answered? And then with Roland, are we underreporting our complications was my thought. So any questions from the audience?
You can also ask questions through the iPad if you wanted to, or just use the roving mic, whichever you prefer.
Thank you. Toby Page, Freeman Hospital, Newcastle. A question for all the panel. How can any of you justify us still putting in data that is being put in automatically through HES when we are all under pressure with time?
I'll take that question. We cannot, and that's why we need to change.
Because it provides data that HES has no chance of giving us on a consultant basis for the foreseeable future. And so I understand time is pressured, but we ought to know our own data, and I think the public ought to know our own data. And until we have a way of HES achieving that on an individual consultant level for benign and malignant disease, I think it's data that we ought to be collecting.
I mean, my understanding is with HES and Model Hospital, we will get that individual data. So therefore, us inputting, for example, the nephrectomy database, which is excellent, the section of endourology, brilliant bit of work, but we now need to move away from that because HES is providing that data for us, or will do next year. So we need to perhaps think about moving on and keeping the momentum that BAUS has, but not looking at the things we've done, but looking forward.
Yeah, and I've had lots of discussions with Kieran about this in my kind of role as representing the section of endourology, and the recognition that HES just doesn't capture certain endourological procedures anywhere near as well as it captures data on nephrectomy, radical prostatectomy, radical cystectomy. So I think there's a problem for us in the benign disease section.
I think the one big hurdle which is apparent, and I speak as a complete outsider to this, is the fact that the data which everybody enters is anonymised. And I think really there has to be linkage between that and HES data, because it's clear that both provide valuable resources, and I think you have to pick the best of both and amalgamate them together. And the only way you can do that is by ensuring that the data that's put into the database is actually traceable and is non-anonymised. And at least that way you can then get follow-up data, which is the one thing that we all need of it. And I don't just mean short-term, I mean long-term follow-up data.
I think you're right. Obviously, we shouldn't be spending our time putting this data. I think there will be some overlap. So as HES gets better and we get more confidence in what HES captures and what we want HES to capture, then BAUS should support what we currently have until we have a sufficient, better process.
And I think I tried to highlight in my talk there's some good and some bad in both systems, and we really now, this is a useful juncture to drill down on exactly, pare down on the efforts. We don't want to end putting useless data that's never used or looked at or is not relevant or whatever. So we need to focus our efforts probably and narrow down the questions to the critical ones that HES can't answer and choose those questions. So for instance, if you put penile implant in, patient comes back to clinic and is very unhappy because you're not counselling him properly and his expectations aren't met or whatever it is, HES doesn't pick that up. You could have 100% unhappy patients and nobody knows about it. So you really need to sort of choose the questions well as to what BAUS and us as a urological body decides to put our resources into.
And yeah, I promise you I'm not religiously committed to spending hours and hours putting in data information. If there is another way of achieving it, that would be fantastic. My concern at the moment is that doesn't exist.
Tim O'Brien?
Question for all of you. Do you think we'd be better focusing the sections on high-quality trials rather than, at best, moderate-level audit? Because if we continue to do moderate-level audit, it may stop us doing the things that really change urological practice. really good trials.
You're right, and as you know, the baggers ran the open trial and we've had suspend. I think the audits can help inform trial questions. So looking at Steve Payne's data, it's quite useful then to look at, for example, we might look at follow-up data and how to follow up urethral surgery. And you can only get good informed questions by looking at large volume data of what we're doing.
Yeah, I agree with that. Again, if we were to change to a model where majority of registry data is captured by another system rather than us physically entering it, such as HES or any other, then those bespoke questions could be clinical trial related questions. But I think in terms of benchmarking, peer-to-peer mentorship and support, even ordinary practice, we need to capture that and review that to make sure that is okay. And that is only possible by moderate level audit.
There has to be a place for both, really. I think one of the difficulties we find, certainly in terms of research, is setting it up. It's far easier to set up an audit project within a hospital, which you could argue in some situations actually gives you is actually a research question. But that's getting harder to do these days, and actually setting up the research, it takes a lot longer and it's more red tape. And I mean, and that I think is a big hindrance towards that, really.
Yeah, and Tim, I think they're not mutually exclusive either, are they? And I think, as has been said, I think the audits inform the questions to be asked, and then we should run with the trials. Whether these sections are the best structures to run those trials, I'm not sure.
Another question from the floor?
Thanks. Ian Pearce, Urology, Manchester. Could I ask, how are we going to get round the fact that while we still have surgeon-inputted data, that's probably, well, it's almost certainly not very accurate, and therefore we're just misleading each other and our patients, aren't we?
Yeah, I tend to agree. I think unless the process can be changed, checked, verified, improved, that we run the risk of just, doing that. And, I think we're pretty much all guilty. I got my nurse specialist to help this year because there's a lot of data to input, and actually complication rate goes up because he's looking for absolutely everything. So bit of dysuria after the catheter comes out is not a complication for me, but for somebody else it might be. And okay, that's maybe not the best example, but yeah, who's reporting it is critical. And I think my feeling is we probably are underreporting it.
I don't think you can disengage the clinician from evaluating this data. I can quote one example of someone I know who entered their data diligently for robotic prostatectomies, and it came back showing that they had a 100% transfusion rate, and so BAUS got in touch with them. And then it turned out that the data manager was looking at the things, seeing the patient who had a group and save, and was ticking the box saying transfusion. So I don't think you can completely get the clinician out of the equation here.
I suppose there are checks and balances with comparing the HES data in some sorts in terms of looking at volume. You're right, outcome can't be measured, and that's partly a probity issue, GMC issue, and how you feel you consent and protect your patients.
I keep saying the same thing, really, Ian. Once again, independent data registries will take out their surgeon bias from this, and that's the solution.
Just on a practical level of entering data, I mean, Jonathan said he spends 4 hours or something at the weekend putting in the data for his perks. Do you think that it's a good use of consultant time to be entering this data, or do you think it's an absolute must that it should be the consultant?
I think it's quite it's so important to look self-critically at one's data. So I don't particularly enjoy putting the data in and the mechanics of it, but actually I think it's quite useful because it does let you look at your own patient cohort, it looks at your own complication rates, your own transfusion rates, and I recognise it is me putting in the data, but I'm bloody self-critical, and I think actually most of us are, and I still recognise that it's not perfect, and then maybe we should be developing other ways of independently evaluating the data. But actually, I think it's quite useful to actually personally look at what I'm up to.
Yeah, well, I think you showed 77% of consultants are entering their own data, aren't they, in your study? Okay, more questions from you?
So 3 questions. Firstly, at the front there.
Hello. Thank you. I do think that the whole point of the consultant outcome publication process was about patient safety, and we aren't particularly good at identifying patients who have died or patients who have been readmitted, had any severe complications. So the things that really are quite catastrophic sometimes we don't enter because we're good at the perioperative bit, but not necessarily the follow-up. So I do think if we're trying to fulfill the requirements of the Department of Health, then you could argue we must use HES data for all that, because on the nephrectomy audit for years, we were capturing about 50% of the deaths from surgeon reporting. So clearly that's, for something that's quite a rare outcome, we're not doing our job properly. But I do think there's so much detail we can capture, and I point to the partial nephrectomy data now that's coming through. I think we as a profession, as a body, can mine this for so much more. And I point Roland in the direction of the partial nephrectomy or the nephrectomy audit evolution to say maybe the urethroplasty audit needs to be updated on a regular basis to try to ask more relevant questions. Sarah Fowler's a fantastic resource to try to make tweaks so that you keep it alive and keep everybody engaged.
Yeah, absolutely. I'm sorry to interrupt. Absolutely. I think these must be alive and active and looked at year on year. And ours, for PCNL data, is very different from what it was originally. It's now got actually a bit too cumbersome, and we've spoken as a committee about trying to really focus again on the data that we want out of it. And so they must be actively managed for them to be to have engagement with the urological community.
There were 2 other questions at the back.
Thank you. Peter Heathcote's my name, from the Urological Society of Australia and New Zealand. Firstly, congratulations to BAUS on an astonishing work of over the last 10 years. The question that's exercising us at USANS, and I'm sure it's exercising you, is moving from data collection to quality improvement and becoming, rather than looking at patterns of care, becoming a policeman, or the dangers of that. What structures or thoughts do you have about your rights and responsibilities in that space?
You floored the panel.
Kieran,
I'll apologise in advance, Kieran. I'm sorry.
Thanks, Peter. I think in relation to this, that we're very conscious of our responsibilities to it. So under the HQIP initiative, HQIP stands for the Health Quality Improvement Partnership. They write a set of guidance which we have adhered to in the main. Okay? We were very conscious of the distinction about outliers versus people who are actually pretty off the scale. And so we've written a policy, a very careful policy, about what our responsibilities are in relation to that. We've endeavoured to adhere to them. So where issues have been flagged up in relation to mortality over transfusion, etc., we have first of all sought to clarify the data with the individuals concerned. And more often than not, as has been alluded to, we've been able to be able to do that. Latterly, we've changed our policy a little bit because we want to move away from being a policeman for this. We're not set up to be a policeman, and I know there's good concerns about this. So, and because of that, where issues have arisen, as much as we do is send a letter to the medical director saying that there's a particular issue in relation to this that we might want to look into, and it's framed in a very neutral way. And in that way, we feel that we're fulfilling our obligations under GMC guidelines.
In the female section, we, much like Kieran said, we've tried with lots of effort to try and not police it, but try and get better data input. And those that don't have, for example, 50% follow-up rates, we won't publish their outcomes. But we still struggle with handfuls of surgeons who do not engage and do not put data in. But we are not a policing authority. And we, as Kieran said, we've written and taken as many steps as we can. But I'm not sure it's our place to stop individuals.
Stephen Mark from New Zealand. Just again, I suppose echoing Peter's comments, the audit sets are really just to provide a minimum standard of care for a whole service, where the service's goal is to provide value for their investment. how acceptable, given the rich data set that you've got, would be a single surrogate measure for outcomes as opposed to what you have, such as readmission rate following simple ureteroscopy or percentage long stay following radical prostatectomy as an alternative single measure as compared to what you have in the way of a huge data set?
Yeah, I think that's a very good point. I think these processes must evolve. I'm not sure if we in the endourology section would want to reduce it to quite to just a single data set, but that does make it very easy to define what your targets are and what you think is a standard you're trying to meet. I think from a personal audit point of view, we should be aiming for more than that. So from the surgeon's perspective, I think we should be aiming for more than that. But from a comparative data set for British urology, that may be where we should be trying to get to.
Tim?
Henry, I was fascinated by your comments about BPH surgery, because I've also been thinking a lot about this, because it's a difficult space, isn't it? There must be 11, 12, 30, 14 different procedures done, and how do we work out which is the one to introduce by, not introduce? How do we know the truth in this, it seems crazy field of outflow surgery? And it did strike me that perhaps that was one area where a prom at 6 months to every patient would be a way of potentially identifying for now and in the future as new things come along, a way of deciding which, in the hands of British urologists, gets the best outcomes. What do you think?
Absolutely, I think your suggestion is an excellent one. It is a minefield. We don't want history to repeat itself. We had this back in the late 90s where novel techniques came along, were adopted for a while, and then we saw patients being readmitted with complications or failure of procedures, and then having the standard TURP done. I mean, that really has to be the test of time and has to be the benchmark to which everything's compared. But what we need to think about really is what do we make the benchmark in all of this? And it has to be something which is easy, reproducible, measurable, and meaningful.
And I think probably a prom is the way to get that. Because it's generally an operation for symptoms, isn't it, and quality of life?
Absolutely.
Yeah, it's probably better than my system, Tim, which is the two questions, I ask myself. One is, do I think, does this procedure feel like a sensible thing for one human being to be doing to another? And secondly, do I think we're going to be doing this in 20 years' time? The answer is no to both of those, and just abandon the procedure from the word go. But I think, that's a fantastic idea. Again, it's without it being mandatory, we know that the ability of BAUS or an individual to actually get that information is very challenging, and to engage sufficient numbers of BAUS membership, particularly those doing the new procedures, can also be very challenging. But
they do it for hip replacement.
If we can make it mandatory, yeah.
I think what I would say as well, it's not just data at 6 months. We know that things can change thereafter, and I think we also need to look into the longer sphere and look at it, as we say, at 1 year and 5 years and see what the real, true, long-term outcomes are from all of this.
I mean, you could say it's after the horse has bolted. There's some very good HES papers looking at prostatectomy and reintervention rates and urethrotomy rates and sphincter rates. So looking over large numbers, you can actually tell in detail. So you could do the same quite easily for BPH surgery, but that would purely be retrospective, of course.
We've actually had one question through the iPad, someone embracing digital technology. So to the panel, how can we be sure that the BAUS audits have resulted in better outcomes since centralisation with its resultant reduction in low-volume surgeons and centres would have occurred in the absence of the audits? So essentially asking, how do we know that BAUS audits have actually caused the better outcomes, or is it just due to centralisation and as a result low-volume surgery is not occurring and it's being centralised?
At least with BAUS audits, we know the outcomes. I think without BAUS audits, we wouldn't have known where we were.
Yeah, I'd agree with Jonathan. I mean, does it really matter? What matters is our outcomes are good. How we achieved it, be that with centralisation or BAUS audits, is almost secondary. As long as we're providing really good care is what really matters at the end of the day, I think.
So I would argue that we don't know the outcomes for cancer prostatectomy, because if I was going to counsel a man, I would like to tell them what's your chance of being incontinent and what's your chance of having an erection at the end of all of this. And that those two questions aren't answered with the data that we have at the moment.
Correct. So I agree with that. So as I highlighted, those are the deficits, if you like, we have in our current prostatectomy audit, that National Prostate Cancer Audit, and True North projects are answering. So there are things to improve upon, no doubt about it, but we've already achieved a lot, really.
And we have seen some in the female audit who realise that they're doing low volumes and have stopped. So we're all busy, and sometimes you don't get a chance to look at your own practice. So actually the audit does help in that respect.
Caroline?
Just a comment really to Tim's comment about TURP. We've got two resources that we don't use at the moment very well. And one is patient-reported outcomes inputted by patients. So if you give them the online registration for a questionnaire, you can resend it at 6 months and ask them. And the other is the Trainees Collaborative, so the BAUS Collaborative. We've got at least 2 big projects here with thousands of patients in them, where the trainees have really been mobilised to recruit all the patients from their centre. And that's something we could look at. And in fact, it's the 3:30 session, so I'm sure we'll be discussing it further.
It's a more generic point, not related to any of the arguments. The last 10 or 15 years, hundreds and hundreds of abstracts, innumerable number of papers in the last 6 hours has been possible because of an individual person tirelessly working in BAUS, and that is Sarah Fowler. And I just wanted to say a very big thank you and a big round of applause for Sarah.
I wanted to ask Sarah, I don't know if you're able to answer this. I mean, we're putting out a lot of the data into the public domain. Do we get a feel for how much the data is actually used by the public or accessed by the public? Do you have any feel for that? You don't think it's used very much by them? So just get the microphone.
Sorry. Conversely, we have had a couple of surgeons contact us whose data wasn't for some reason on NHS choices, and a patient had miraculously found the page on my choices and wanted to know why their data wasn't there. So, but I would say very, very small percentage.
Okay, interesting. There's one more question.
Patrick Meffin from New Zealand. Just coming back to that question of BPH surgery and the wide range of options that are available, virtually all of those have come into practice through industry-sponsored trials, and certainly having been involved in a few of these, I think there are some fundamental flaws in those, and I wonder therefore whether ultimately the real world is where these technologies do get tested, and the key thing is that there is a process of audit that allows ultimately for us to work out in 10 years' time whether they were good or bad. I mean, it might be imperfect, but unless we're going to take on the role of funding clinical trials, I don't think we'll necessarily get fantastic answers from industry.
I just wanted to ask the panel, it was referred to this morning, the National Clinical Improvement Programme Model Hospital. Do you think that online portal for a consultant to access all their metrics is going to be the solution? Do you think it will give us what we need, or do you think it's just another way of duplicating data again?
I suppose we have to wait and see how accurate it is. The FIN portal had lots of problems, but you have about 9 months to make sure the data is correct, and you can keep going back until it's correct to the private hospital network. Yeah. And that's all put in by the private hospital, so I imagine the model hospital will have the same issue.
I think the pilot's due to start this year. I think it's paediatric surgery, general surgery and urology that have been chosen to pilot it with a general rollout next year. So it's all quite soon, I think. Were you going to say something, Henry? No.
So we thought we'd finish, but we'll ask you those questions again that we asked you at the beginning. So let's see if your BAUS apps work and see if we can help BAUS try and make a decision about how we want our registries to run. So if I can just have the last 2 slides on the chair's presentation put up, please. So I guess this is the question that BAUS really wants us to answer. Should BAUS continue to fund the registry through member subscriptions? Yes, no, or not sure?
I don't think there's been much change, actually.
Yeah.
It's about 50.
So a problem for the BAUS president and future presidents of how we're going to fund this, I suppose. Great, thank you for that. And just one last one. The last slide on that, please. BAUS should discontinue the current registry and utilize other existing data instead, such as HES. I guess what I don't have is how many of you are voting here?
Oh, we've got more people in the audience than we had at the beginning, I think, so the numbers will be different.
So not much change from that is the honest answer. So thank you very much. A big thank you to all the speakers. Thank you to the great audience, and a thank you to my co-chair. Thank you.
Thank you.
Yeah, absolutely.